Hi friends, today we are going to discuss about diabetic ketoacidosis. How can we diagnose diabetic ketoacidosis? There are four diagnostic criteria to diagnose DKA, diabetic ketoacidosis. They are: first one, blood glucose must be more than 250 mg per deciliter. And second one is serum bicarbonate must be less, that is less than 18 millimole per liter. And there should be a presence of ketone bodies in urine, and pH must be less than 7.3, that is acidosis. And what are the clinical features the patient presents with? Patient presents with abdominal pain, vomitings, altered mental status, dehydration, hyperglycemia, unstable vitals, and even if we take the urine sample for ketone bodies, there will be the presence of ketone bodies in urine. So a patient presents with abdominal pain, vomiting, altered mental status, dehydration, check first, or with unstable vitals. Then we need to check for blood glucose level. It will be raised, and if we check the serum level, serum bicarb levels will be low, and in urine sample we can find the presence of ketone bodies. In ABG we can find acidosis. So how can we manage this case of diabetic ketoacidosis? First one, we need to treat for, here dehydration is symptom is there. Now we need to treat first that. First we need to monitor vitals A, B, C, airway, breathing, circulation, followed by, first you need to administer IV fluids. How much IV fluids we need to administer? We need to administer 2 to 3 liters of 0.9% NS in 1 to 3 hours. Along with IV fluids, we need to simultaneously administer the short acting or regular insulin. Remember, only short acting or regular insulin we need to administer, not long acting. So how we will administer this? Initially we need to administer 0.1 units per kg IV bolus we need to give to the patient whenever he comes. This diabetic ketoacidosis patient came to the clinic with the symptoms of altered mental status and dehydration. So we are correcting this dehydration by IV fluids, and hyperglycemia is corrected by using this short acting or regular insulin. How much we gave? 0.1 units per kg IV bolus, and IV fluids we have given 0.9% NS 2 to 3 liters initially in 1 to 3 hours. After 1 to 3 hours, we need to half it, like 0.45% NS at the rate of 250 to 500 ml per hour we need to give. This is called step down approach. We are reducing the percentage of NS. Initially we have given 2 to 3 liters IV fluids in 1 to 3 hours, followed by 0.45% NS at 250 to 500 ml per hour. Continuously we need to monitor plasma glucose level, like blood glucose level. Whenever blood glucose level reaches 250 mg per deciliter, then we need to add 5% glucose to this 0.45% NS. And we need to change this rate of giving, like from 250 to we we need to give like 150 to 250. 250 to 500, change it to 150 to 250 ml per hour. See, initially we have given this insulin of IV bolus, but it is not enough. We need to continue it by 0.1 units per kg per hour. IV infusion also we need to keep 0.1 units per kg per hour. Infusion also we need to keep. Whenever if the blood glucose reaches 150 to 200 mg per deciliters, then we need to reduce this amount of insulin given to the half, like 0.05 to 0.1 units per kg per hour IV infusion. See, every time we need to, whenever we are giving insulin, we need to check for potassium levels in the blood. This insulin is an enemy of potassium. So whenever we have given insulin, it reduces the potassium levels. So we need to check for potassium levels. If it is reduced, we need to supplement it. So check for potassium levels. If the potassium level is between 3.5 to 5 milliequivalents per liter, then give potassium at 10 milliequivalents per hour. If it is less than 3.5 milliequivalents per liter, then give more potassium, like potassium at 40 to 80 milliequivalents per hour. If more than 5 milliequivalents per liter, then no need of potassium supplementation. It is a normal level. Potassium supplementation. So this is the entire management of diabetic ketoacidosis. First, the patient presents with the abdominal pain, vomiting, altered mental status, dehydration, unstable vitals. When we check the blood glucose level, it is showing like more glucose, blood glucose how much more than 250 mg per deciliters. When you then check electrolytes, the serum electrolytes showing the serum bicarbonate showing less than 18 millimoles per liter. Then in urine sample there is a presence of ketone bodies. pH of ABG sample is less than 7.3. Then our diagnosis is diabetic ketoacidosis. As the patient is dehydrated and hyperglycemic, we need to give first initially IV, monitor ABC and administer IV fluids at the rate of 2 to 3 liters of 0.9% NS in 1 to 3 hours, along with administer this regular insulin of 0.1 units per kg IV bolus. Then followed by IV bolus, we need to keep insulin of IV infusion like 0.1 units per kg per hour. Monitor the blood glucose still, and we need to administer after 1 to 3 hours 0.45% of NS at 250 to 500 ml per hour. Then monitor glucose levels. If blood glucose level reaches 250, then decrease the IV fluids rate to 150 to 250 ml per hour and add 5% glucose. And this, whenever blood glucose reaches 150 to 200 ml, then reduce the insulin level also to 0.05 to 0.1 international 1 units per kg per hour infusion. And along with the blood glucose monitoring, we need to monitor potassium levels. If more than 5, no need to administer potassium. If 3.5 to 5 milliequivalents, then give 10 milliequivalents per hour of potassium. And if there is less than 3.5 milliequivalents per liter, give potassium at the rate of 40 to 80 milliequivalents per liter per hour. So this is it, guys. Management of diabetic ketoacidosis. Thank you. Please like, share and subscribe.